All right, let's start. I see we are live on Facebook and we have about 110 people who've joined us. Good afternoon, everybody who's dialing in from the Africa region as well as Europe. Good evening to those who are further to the east from Korea and China. I know sometimes we have folks from China dialing in. And then good morning to those who are further west from us, from the US and South America and beyond. We know these are challenging times with the US election results, still many of us waiting to see where those land, but the show must go on, and therefore really excited about this conversation that we have today, which is a discussion on Africa's preparedness for the COVID vaccine. Many of you know that this is one of the things that's talked about as being so critical for the world to find a solution towards COVID. And there have been lots of clinical trials that are ongoing. I think we have about 52 candidates which are currently in the pipeline, about another 200 that are in preclinical kind of development. But the eternal question many of us have been asking is, even if we get the vaccine correct, are we going to be ready? And what are the things we need to do in advance to make sure that we are ready for the African continent to utilize this technology and therefore get lives and livelihoods back. Dr. Githinji Gitahi will be leading today's conversation, so I'll hand over to him shortly on what is a really exciting panel with members from the Gavi CSO community, a community health worker, PATH, who are partners of us during this webinar, as well as WHO AFRO, to really get into the details of this. But before I get to that, I'll want to quickly share with those who've dialed in an initiative that Dalberg has recently put together, and I'll ask Grace to please put up the slide, that is really thinking about the equitable distribution of COVAX, so the COVID-19 Vaccine Equity Project, that is really looking to turbocharge the thinking and the planning from the ground up on what it is that would be required to really absorb, once the vaccine on the shores of a country, what will be required to ultimately get it into the hands of the health workers and ultimately into the bodies of citizens. And so this is something that we launched last week, really beginning to build momentum around. And so welcoming everybody who is on the call to engage with us in building and developing that. And you can see the micro site that we have there, vaccineequity.org, is an easy way for you to learn more about the initiative, but also, more importantly, be critical thought partners as we are developing this archetype. But I'll pause there from my end, and I'll hand over to Dr. Githinji, who is our pilot for the day. Dr. G, over to you.
Great, Edwin, thank you. And congratulations for that, by the way, for that vaccine equity initiative on the back of COVAX. COVAX has been in our mind for some time, building great momentum. But today, you have heard a lot from Edwin and I over the last year or so, almost a year. And our last conversation a few weeks ago was on education during and after COVID. And I think in that conversation, and in every other conversation of reopening the economy, education, and every other conversation we've had, the vaccines have featured in every single conversation, because people have seen vaccines as a way of moving forward to actually reopening economies and moving forward to have schools continuing. So vaccines have been central to every single conversation. And therefore, for us as Amref South Africa and Dalberg, we are very keen to have this conversation about, so when do they come? And also, how do we get them to the last mile? How do we make sure they go to the last mile? I want to reflect on an article I read from Amref Gupta, who is works at Gavi as the Deputy Executive Director, and she was reflecting on the 3 V's of vaccines: the vaccines, the vaccinators, and the vaccinees. And we will be discussing those 3 V's in this conversation, because if you look closely at our panel, we have Dr. Richard Mihigo from WHO. Richard is in charge of vaccine preventable diseases at WHO AFRO. So he'll be talking about policy, preparedness, the gaps, and all these areas, and he'll be speaking to us very shortly. But we also have Emmanuel Mugisha, Dr. Emmanuel Mugisha from Uganda, and Emmanuel is actually the country director for PATH. And PATH has been involved on the research side, on the supply chain side, and also in practice at country level. So Mugisha will be sharing about how is it looking in Uganda in terms of preparedness. Then we also have somebody who is a community member, that is Margaret Kilonzo, who has been involved in multiple vaccination programs as a vaccinator, especially polio, but also a community member because she's a community health worker and therefore works closely with the communities. So she'll be giving us that perspective. And finally, we have Dr. Chizoba, who is an advocate, a physician, but also an advocate for vaccine access. So you can actually see we are covering all the 3 V's. We are covering the vaccines themselves, we are covering the vaccinators, and we are covering the vaccinees as well. So without taking too much of your time, what I would like to do is ask Dr. Richard Mihigo to actually come in and reflect very quickly on 2 areas. One, what is WHO AFRO doing to assist countries in this preparedness journey? Because we know very well, it's easy to say we are waiting for the vaccine to be discovered, but when the vaccine comes out, the journey to getting it to the people, to the last mile, is really going to be a big challenge because of all the challenges you've seen of hesitancy, supply chain, preparedness. So you could comment on what WHO AFRO is doing around this, and what are some of the biggest gaps and challenges you're seeing that countries need to overcome in this preparedness. So over to you, Richard, and thanks for joining us. And we are really grateful that you could make it for this conversation.
Thank you very much, Dr. Githinji, and really very much happy and excited to join this webinar series that are organized by Amref and Dalberg. My name is Dr. Richard Mihigo, as we have introduced, the coordinator for Vaccine Preventable Disease program in the WHO African Regional Office, but also the co-lead of COVID-19 response for WHO in the African region. So I think if we look back 10 months ago, when this pandemic really started, we have seen that our lives have completely been put ups and down. Our normal life, has been changed. The way we are living, the way we are working, our economies have been really very much affected. Countries have tried as much as they can to respond to this COVID-19 pandemic with all the tools that are currently available, by putting in place quite a very, to be honest, effective public health and social measures that have at least to some extent spare our continent from the catastrophe that was predicted at the beginning. So in WHO, since April this year, working with other partners, the access to COVID-19 tools, the ACT Accelerator was launched, which is a global initiative that's really aimed at speeding up the development, the delivery, and more importantly, the use of essential tools to deal with COVID-19, not only vaccines, but also therapeutics and diagnostics. Maybe I will focus more on vaccines because this is the subject for today. And as part of the ACT Accelerator, the COVAX facility was set up, which is led by WHO, Gavi, the Vaccine Alliance, but also CEPI, the Coalition for Epidemic Preparedness and Innovation. And the objective really was to see how at global level, there could be a mechanism by which the demand for vaccines, but also more importantly, the equitable allocation of the vaccines can reach all the people at the same time. So at WHO, what we have been doing to support countries to access vaccine, working with many partners here on the African continent, and mainly Africa CDC, UNICEF, but also other partners, including member states themselves. We have set up a regional task force for COVID-19 vaccine readiness and delivery, which is really a task force that is now supporting member states to get ready once the vaccine will become available. So we have developed a tool, which is a vaccine implementation readiness assessment tool that we have shared so far with all the countries to try to understand what is the level of preparedness at country level, what are the gaps that exist, and how could we anticipate some of these issues when the vaccine become available so that we can support better member states to deliver the product. So what we have learned since a couple of weeks now by analyzing the data that are coming from this vaccine introduction readiness assessment tool is that the gaps in terms of deploying the vaccine up to the remote area, the gaps are really enormous. I want here really to remind that this will be one of the unprecedented vaccination drive that our continent will be going through, because it's not the traditional campaign that we are doing to reach under 5 children or children up to 14 years. Here we are talking vaccinating the entire population, vaccinating a majority of population. And it is estimated that if we really need to reach a herd community, a minimum of 60% of the population has to be reached. So if we looked at the population at the African continent, 1.2 billion people, 60% of those people, we are talking about almost 700 or 800 million people. If we have to deliver 2 doses of the vaccine, because this is the early indication that we are getting from the vaccines that are in the late stage of clinical trial, we are talking about here deploying close to 1.5 billion doses, which has never been done in history for the moment. So it will be a gigantic task ahead of us. And I believe that the initiative that you have launched to discuss these issues ahead of time. WHO will definitely be leading this process, working with Africa CDC and member to make sure that from the acceptance and the delivery of the vaccine, logistics, cold chain, etc., we worked with the partner to make sure that once the vaccine become available, all of these area will be already fine-tuned. And I would like to conclude by saying that we are seeing a lot of solidarity going around, and particularly through the COVAX facility, funds are currently being raised to make sure that countries that are not able to afford this vaccine cannot be left behind. And this is one of the bitter lessons that we learned from the H1N1 pandemic in 1998, where Africa was the region which was least prepared to actually receive the vaccine. So we want really to avoid that such situation happen again. And if the vaccine become available, it has to be made available equitably to everybody. So thank you very much, Dr. Gitinji.
Thank you, Richard. Thank you very much for that oversight. And I'm really glad to hear about the vaccine readiness tool. And if I could get back to you, just what are the top two, as we have seen, you know, the participation on this webinar is very high. I'm seeing more than 200 people on this webinar, which really tells you the importance of this. And I'm seeing people from Burkina Faso, Seychelles, and everywhere else. What are the top two challenges you are seeing the countries having that we need to overcome? If you could just reflect on that. And then when I come to Emmanuel, I'm going to actually ask Emmanuel to think through this because PATH has been involved in vaccine production. So you understand that end. Now, if Richard is talking about 1.5 billion doses for Africa alone to reach 60% herd immunity, what does it take to produce 1.5 billion doses? Because I don't think there's any single manufacturing company that has the capacity to produce 1.5 billion doses of vaccines in a short time. So, Emmanuel, you could think about the production side of that, and I hope you can hear me on that. But in the meantime, Richard, top two gaps you're seeing from this tool?
Yeah, we are seeing quite very interesting data that are now being collected through the tool. Number one, it's really the planning process. We know there are a lot of uncertainty about who should get the vaccine first, who's need to be prioritized in the country, which process is going to be used at country level to make sure that if the vaccine become available, it reach first those who are really in need of that. And I think from the data that we are seeing emerging from country, that was not really very clear on how people should go about. Fortunately, WHO has developed through SAGE a allocation framework that has got really an equity lens throughout this process to make sure that those who are really most in need will get the vaccine first. Secondly, logistics. I think delivering the vaccine up to the very, very remote area will really require that we come up with a very innovative way of looking at delivery of the vaccine. The current established cold chain capacity, which is now being evaluated in many countries, is it going to be enough? So we are seeing quite a very innovative solution that countries are starting to propose on how to mobilize internal capacity, how to surge their logistics supply system in the country in order to be ready by the time that the vaccine will become available to reach the very remote areas that we do have in this continent. But I can elaborate more on that during the conversation.
Fantastic. Thank you so much. And Richard, if you have any links that are public on SAGE, on these tools, you could, just be kind enough and post them onto the chat so that people can pick them up. And now I come over to Emmanuel. I think it's a very good segue from Richard to you because he's talking about, for example, how do we build this cold chain capacity I think I saw somewhere we may need 15,000 flights to deliver this vaccine. And I think I saw, millions of numbers in one of the papers here on the numbers needed to actually, in terms of cold chain capacity, very, very high cold chain capacity needed. So you could comment on how do you see this on the first question on production capacity. Secondly, what are you seeing in country, reflecting on what Richard has shared, and how do we build that capacity to help countries to prepare? Syringes, needles, PPEs, they're all these things that are needed. How do you approach this, Emmanuel? Over to you.
Thank you so much, Dr. Gitai, and good afternoon and good morning, everyone. And thanks again for organizing this webinar. I think this is very good as we discuss COVID prevention approaches. Good that we are talking about the vaccine, because as you know, vaccines are the most cost-effective healthcare interventions that are most reliable because of so many issues that we know. As PATH, we've, for the last 20 years or so, we've been involved in vaccines at various levels, basically leveraging on the scientific and global health expertise. And of course, with our deep connection with communities, we've been quite successful in getting multi-sectoral partnerships and also building support in countries, especially as we advance equity and vaccine coverage in various areas. So as I mentioned, definitely the vaccines are one of the best approaches to prevention, but a vaccine is only useful if it gets to where it needs to go. So if it stays in the vial, then it will not play its role. So we need to have a very good system to make sure that vaccines are delivered in time and at the right quality, at the right, in the right temperature, for example, so to say, and the right people at the right time, the shortest time possible. Because if you don't, then actually you are not necessarily, you are not getting a lot of benefit from vaccines. So the vaccines for COVID definitely will not be different from the other vaccines that we've actually dealt with over the time. And these vaccines are not coming they're not coming in an empty space. They're coming and finding systems that have been built over time, especially in the African continent. We've actually been building capacity together with other agencies in terms of vaccine development, vaccine delivery, and vaccine distribution. Now, when we look at the COVID vaccine, for example, there are many issues that we have to think about. There is the awareness and appreciation of the vaccine. We may assume that everybody will appreciate and want the COVID vaccine, but it may not be the case. I'm seeing a paper, I think, from South Africa, where I think 64% are saying, no, we don't want the vaccine. And so you have to deal with that population. There are lots of myth and misconception about vaccines, so you have to deal with that. There are issues around eligibility. This is a different vaccine from the ones that we've seen, where there are specifics around the population, usually children and infants. But this is a vaccine that is actually supposed to be reaching to everyone, right from age 1 up to age 100 and so. So how do you decide who actually gets this vaccine first, given that there are limited quantities of this vaccine? There are issues of distribution. Are we going to use the normal distribution channels that we've always used? If we want to get this vaccine out very quickly, can we think of some other private partnership approaches? Coca-Cola, for example, reaches every part of the country within a short time with their products. Can we think about how to use that? How about administering this vaccine? Are we going to put it at the health facility and ask people to come to the health facility to get this vaccine? Or are we going to look at other avenues that are normally not used in vaccinations? Schools, for example, some of them are open, some are closed. How do you use those? Some other communities, how do you use those? At the same time, we are trying to observe social distancing in this era. So how do we make sure that we actually deliver a vaccine that is supposed to actually prevent COVID and at the same time, not necessarily increase infections where we are administering it? Who administers the vaccine? We know we have very limited health workers. So are there some other people that we can actually turn to, for example, retired health workers? Can we approach those and get them back into actually quickly deliver this vaccine. We have the procurement, we have the transportation, the shipment that you talked about. How many flights do we need? Sustainability. I mean, we may need 1 or 2 doses, but how often? As of now, we haven't known how long the immunity might last. For example, we might need to be vaccinating every year. So how shall we be prepared for that long haul when we are vaccinating? So there are so many issues that are involved, especially in this COVID vaccine, as we think through. Now, for Uganda, we've definitely been involved in this. And as you know, Uganda has some little bit of history when it comes to vaccine research. For example, Uganda was the first country to be involved in HIV vaccine research way back in 1990s, where I was actually happy to be involved. So we've had that history of actually venturing into some of these very gray areas where many other people may not have ventured in. We also have had, for example, the demonstration projects around HPV vaccine, which is also one of the vaccines that is not a vaccine that is a regular vaccine, but one of the a little bit more complicated vaccines to deliver to the target population. So we have had some bit of history where we can borrow in order to actually make sure that the COVID vaccine is distributed so fast. So very, very briefly, where are we and what are we doing in Uganda? So in Uganda, we've done quite a lot, I should say, in terms of preparing for the COVID vaccine. There's been, the Ministry of Health has set up a coordination committee, which is basically coordinating the planning and overseeing and eventual delivery of the COVID vaccine. And it has about 9 subcommittees looking at all different areas. I may not go through all these committees. As you know, many of you have been involved in vaccinations. You have committees about communication, advocacy, and all that. But I wanted to highlight a few of these committees that are a little bit special to COVID vaccine. One is the prioritization committee. This is the committee that is looking at, if, for example, you have 20% of the doses initially of the COVID vaccine, who are the key priority groups that are supposed to receive this vaccine? First and foremost, we may want to deal with the front healthcare workers. And then who is next? Who are the others? You might say, okay, let's look at those who are high risk. Let's look at those who are more vulnerable. So there is a committee that is collecting data around all these vulnerable groups or high risk groups, and then trying to make sure that then there's prioritization along the line in terms of who gets the vaccine. Of course, there's a committee around resource mobilization and planning. This is a little bit rare. In most of the vaccines that we've had, it's usually the government that is involved in looking for resources for vaccines. But this is a vaccine where we think a lot of private entities have a lot to play in terms of making it available, in terms of course, contributing financially, but also supporting in terms of the distribution of the vaccine. So we hope to have a lot of involvement of the private sector. And indeed, some of these groups have already been co-opted onto some of the subcommittees who are looking at how quickly we can deliver this COVID vaccine. And then you have other committees, of course, that we know of that are looking at regulatory communication and awareness. As I mentioned, people need to be aware and appreciate the seriousness of the COVID of COVID to be able to actually accept the vaccine. And I can't say that we've reached a level where everybody has actually appreciated the seriousness of the COVID pandemic. But we have to ensure that we've done that to make sure that then we can build on and deliver the vaccines. So there's quite a lot that is going on at the country level. As Richard has also mentioned, we are also feeding out this readiness tool, which the WHO has developed. We are feeding out that tool to really make sure that we are moving along and measuring our success and readiness in terms of getting the COVID vaccine. I think as from the Ministry of Health, the first dose should be delivered as early as April 2021. So we need to work backwards to make sure that we have all that it takes. Everything is in place to make sure that by that date, we've actually delivered the first dose of the COVID vaccine. That's what I can say for now. I'll be adding on more later.
Thank you very much, Emmanuel. You've covered quite significant ground on some of these issues. And there are many, many questions coming up related to some of the things we are discussing. And we'll come to question time. So I don't to go through those now. What I would like to do is ask Margaret Kilonzo. So Margaret Kilonzo from Kenya, community health worker, community member where you're living, and you've had all these things presented by Richard and Emmanuel, and looking at WHO level, path, and policy level. But what's happening on the ground, Margaret? What's going on? What do we need to anticipate? And what are those challenges you think we need to overcome quickly and the ones that we can wait and overcome later? Over to you, Margaret.
Thank you so much. I'm a community health worker from Kenya. What I can say, this idea of the vaccine is very important. It is a good idea if planned well. And it can also be a relief to some of our community members. But in order for this vaccine to succeed, we have to involve all the stakeholders in that community. We are talking about the local administration, CHIUs, CHCs, even the community itself. And by doing this, we should make sure the community are involved from the process, from the word go, so that they can own the process. Because if you fail to do this, they'll be saying this is somebody's project. It is not ours. And they will have that resistance. And in order for this idea to succeed, we should use the community health workers. Because for one, they understand the community very well. They have the households where they can talk about everything to these people. And for these community workers should be empowered with knowledge to understand the vaccine very well, to know the advantages, or to know what surrounds about the vaccine, so that they can go back to the community and empower the community members. And they can do this through forums, churches, so many, but only if the community will be, they will be there from the start. They'll be involved, because working in the community is not very easy. And there are so many concerns which they have. For example, I've heard some of my colleagues talking about sustainability. There are so many concerns which should be addressed before in bringing the vaccine to the community. For one, in this community, there are so many myths and misconceptions surrounding all these vaccines. They should be addressed. How? Who will get this vaccine? In case it backfires, what happens? The side effects, sustainability. Who is to be given this vaccine? The cost, availability of this vaccine. So this, I think it is high time we should involve the community health workers, empower them, empower the community. So many vaccines have been administered in the community, and these are the same people. Now you are talking about COVID-19 vaccine, which surrounds so many myths. I think we should empower these people with the right knowledge so that they can accept the vaccine. Otherwise, they just say this is not ours. I think for now I can say that, but I'll come back later. Thank you.
Wow. Well, I'm sure Richard and Emmanuel, you've heard, and all the people, now we have 211 people participating. There are government officials here, there are people in policy and other areas. And, recently I was listening to, we were training journalists on the COVID vaccine, and one researcher from South Africa presented some data. And he was presenting some qualitative data where a community member actually asked, why is it that when we go to the hospital, we don't find the drugs we need? My child has a fever, I want fever medicines. But these other vaccines, you bring them to our houses. Why should we trust you if what we need, we can't find, but what you want to give us, you are coming to our houses to give it to us. And this is what I think Margaret is reflecting on in terms of the trust element of the community. You're raising issues around fear of side effects, who is responsible, and the community is confident enough that the vaccine is safe. I've seen a question here on safety, especially in view of the acceleration of the COVID-19 vaccine that's something we'll come back to address with our panelists and when we get to question time. The cost, is it going to be free? We know that the COVAX is delivering fast, about 2-3% of what the country needs. So in Africa, that's basically 30 million people for the first load of COVAX vaccines. Who are the people who are going to receive this? So, and how are they going to be selected? So let me come now to Dr. Chizoba, because there are many questions here around. You're a physician, you're also an advocate, you're sitting in the Gavi CSO Steering Committee. There's actually a question from somebody here on what the role is of Global South. Is Global South being represented on the decision-making bodies on COVAX or ACT Accelerator? And is CSO represented in these conversations? And what will be the role of CSOs in these decisions that are being asked by Margaret and others? So Chizoba, over to you. And maybe if okay with you, we could actually ask to hold and you read the call to action at the end rather than during your, so that it fits after all the conversations, because, you know, then you could reflect on everything. So we could read the call to action before the close during wrap up. So maybe you could take some of these views from your point, to hear from you.
Okay, thank you very much for the invitation. Dr. Chizoba Wonodi has been introduced, and I'm representing the Gavi CSO constituency platform. So this is a platform of more than 800 civil society organizations across the world that are really focused on immunization and advancing the cause of immunization. We know that civil society organizations are a diverse group of, it's really a sector. The civil society is a sector. You have the government sector, you have the private sector, and then you have the civil society sector. And within our platform, we have national NGOs, we have people in academia, we have international NGOs, patients groups, think tanks, consultancies, also religious organizations. So it's a broad swath of the non-governmental sector. And some of the things that we've really been driving for, and we see our role in really, is to advocate and to ensure that governments, both in northern countries and southern countries, are held to account to ensure access, equitable access to these vaccines. So we are really holding up the principle of solidarity, and we are requesting and pushing and fighting really for everybody to have access to the COVID vaccines. Another thing that we do as the voice of the community, because civil society work very closely at the community level, and we are able to bring up the perspectives from the community, just like what my sister Margaret has talked about. Civil society is able to elevate those concerns at the decision-making levels, at all levels, both at the local, national, global level. And our role really is to make sure that we are building trust within the community and that we are improving health literacy, because a lot of these misinformation that we know is percolating around COVID is really because people don't know. And so we have a role to play to ensure that we pre-position the education, we pre-position the communication with communities. We are able to counter the rumors and the conspiracy theories, which are so prevalent with this COVID, much more than we've ever witnessed before for any vaccine preventable disease. So we have a lot of work as CSOs, working, of course, in partnership with the government and other sectors to ensure that the community has the right information that they need to make decisions. We have to counter distrust. We have to counter vaccine hesitancy, and there's much more that we can do. But in order for us to be effective in this, we need to understand what the people think. We need to understand where they get their information from. We need to understand who they listen to, because the messenger sometimes is as important as the message. And so in order for us to understand this, I propose we really need hyper-local research, not research in the in the sort of high science ivory tower sense, but research that is like listening to what is happening in the community. So we need to put in place systems that will listen through religious organizations. When you go to churches, you go to mosque, what are you hearing about what people are saying about the COVID itself or the COVID vaccine? And then how does the health system sift this information and then use it to design their communication messages and communication approaches? The old communication approaches may not work very well at this with the COVID, because we know that we're dealing with a new disease, we're dealing with a new cohort of recipients. So that communication, addressing misinformation is a critical role of CSOs. Another thing CSOs really need to stand strong around is making sure that the prioritization, Richard had talked about prioritization, and so did my brother from PATH. Because we're not going to have enough vaccines in the short term, we need to make sure that when the committees that have sat down and said, we're going to prioritize health workers, we are going to prioritize older adults, we are going to prioritize people with underlying conditions to receive the vaccines first, we need to be vigilant to make sure that people don't jump the line. So maybe political leaders or people who have influence do not jump the line and go get vaccines before these other priority groups. So civil society have a role to make sure that the prioritization sequence that has been put in place is adhered to. Another thing we really need to be advocating for as civil society organizations is this issue of the long-term solution to vaccine security. I mean, COVID has really laid it bare that many African countries are vulnerable in a sense, because I don't know of any African country that is manufacturing the COVID vaccine. I don't know of any African country that has done bilateral deals with manufacturing companies, which is not advisable anyway. But what it really says is that we have left our continent sort of open to vaccine insecurity. We need to really push for the capacity to manufacture vaccines in our continent. Not every country in Africa needs to manufacture vaccines, no. But there has to be some regional hubs where they are equipped with technology transfer, with the basic science, with the funding, with the support to begin vaccine manufacturing. It doesn't even have to be the high-end vaccine manufacturing. We can start with packaging, then we can move on to being a manufacturing hub before we can go on to actually developing the vaccines itself. But the time really is now for African countries to take a very bold step in putting this in place. We've been talking about this for a very long time, and COVID has really made it imperative for our government to take this seriously, as well as our private sector to invest in this. And I'm also calling on the international organizations to support this effort to make sure that there is vaccine manufacturing in Africa. Like I said, not every country needs to manufacture, but one or two strategic hubs should be doing that. Look at today, because India took on that challenge and started vaccine manufacturing, the world is able to have COVID vaccine doses manufactured because India has come to the rescue. So this is something that needs to be expanded to the African continent. Another thing we as CSOs need to do is to ensure that we are advocating for affordable prices for the COVID vaccine. It's really, really heartening to see the effort of the COVAX facility. It's an insurance, it's really an insurance policy for countries all over the world, including African countries, to make sure that at least we would have the minimum required doses to protect our countries. However, there are co-pays, right, that will be associated, or co-financing, whatever the term may be. And the co-financing should be such that it is affordable for many African economies. We know that COVID has really hit the economy really seriously. I see from a World Bank estimate that something around $37 trillion or so sub-Saharan Africa has lost in terms of production. So we know that, we even see it in the country. We see it in the country that we are reeling from the economic impact of this COVID pandemic. So the issue of affordable pricing, it's very, very important. And that's something that CSOs must put on the front burner of the advocacy system.
You raised such a critical point.
Yes, Edwin, please take it over from here. Thank you, Chizoba. Thank you very much for those very elaborate points there. And now I'd like to ask Edwin to come in, because there are quite a number of questions. Over to you, Edwin.
Yeah, thanks, Dr. There's one point that Chizoba mentioned, which I'd love to pick up with both Emmanuel and Richard, which is exactly this question of research and production and manufacturing on the African continent. And I think it would be great to just shed a bit more light on one side. We are seeing, different, COVID subtypes develop and mutate, right? Which then means there might actually be a divergence of what is the actual virus that is, that is spreading across Africa versus some of the other ecosystems, especially now that, travel and trade is so limited. So you're not getting a lot of back and forth, and it's more different subtypes winning in the evolutionary battle. So it'd be great to understand where the research sits in terms of making sure the vaccine that is generated is actually relevant to the vaccine type that is becoming prevalent across the African continent. And then just as importantly, on that question of manufacturing, that we have lost, we don't want to lose this opportunity to create and build a really strong manufacturing base, which has those other positive impacts of creating jobs and creating wealth in our local economies. How do we think, how are you guys thinking of seeing and thinking about those in your respective spaces? Maybe we'll do Emmanuel first and then Richard after.
Yeah, thanks so much, Edwin. Definitely, those are very important points and very critical areas to consider. First and foremost, on the research, I think on the African continent, I should say that we've actually really been involved in a lot of research. As I mentioned earlier on, during those early days, mid-90s, I think Uganda took up the HIV vaccine research, where no one would actually want to venture into. And that actually opened up a lot of doors in terms of doing a lot of more of this research. And since then, we've actually continued to do a lot more research in these areas. Now, with regard to the vaccine and COVID-related research, there's a lot that is going on at the country level. For example, in the treatment of COVID, there's been a lot of research that has been happening in Uganda. For example, the use of plasma in the treatment of COVID-19 and others. So it's not that we are sitting down and waiting. However, when it comes to vaccines, I think we should agree that this is a little bit high-tech, quite a little bit complicated. Nevertheless, we are not saying because it's so complicated, it's we can't get involved. No, we are definitely looking at ways of how we can actually get involved. And as Dr. Chizoba mentioned, we are trying to see, to look at some of the potential institutions where, for example, the institutions that could work along with the other developed institutions in terms of moving forward some of the vaccine research. For example, here we have what is called the Uganda Virus Research Institute. This is one of the biggest institutions doing a lot of research in virology-related areas. And they are already looking at some of these areas and some of the areas where they can actually participate in terms of the COVID vaccine. I mean, right now, yes, there's a lot of vaccine development, and this may say is like the first generation, but we have the opportunities of doing, for example, the second generation vaccines, because, usually in vaccines, we always see that there's the first generation, the second and third. where you actually improve on the existing. And I'm really looking at a very big likelihood of participating in especially the second generation vaccines, vaccine development, because this will be necessitated by the demand of the vaccines. We've heard from the various talks, we need about 1.5 billion vaccine doses in Africa. This may not be a one-off. It might be continuous. So meaning that actually we need to have capacity here. So these are some of the areas that the team is already looking at. And I'm very certain that Uganda Virus Research Institute is definitely one of the areas that we'll be looking at vaccine research, as well as vaccine manufacturing. And the government is trying to put a lot of emphasis in terms of this. And I can see why this is likely to be, because, for example, during COVID and when there was a lot of requests for preventive measures and different drugs, some of these factories around were repurposed to actually produce some of those COVID-related prevention tools. So this is likely to be the case, that there's a lot of demand for the vaccines, and we are likely to go into this. I think the hesitance or the slowness in getting into vaccine research has been maybe the fact that there's always enough supplies. I think that has always been the case, that there's always enough supplies, especially from the developed countries. But this is not going to be the case with COVID-19. So exactly. I'm definitely very sure that we are getting into this area.
Exactly. And Dr. Richard, I see you've been fairly active in the Q&A session, answering some of the questions. Do you want to share with a broader audience the perspectives you've been sharing about the COVAX facility and countries' ability to access at least part of the vaccine when it becomes available, because that is a major question that's coming up.
Yeah, thank you, Edwin. Yeah, I will be very, very happy to do that. Maybe just to say a few words on the R&D and vaccine research. I think this pandemic, unfortunately, have to some extent revealed some of the limitation and the weaknesses in the research and development capacity in the African continent at large. We know very well that the African Union, through the 2063 vision, has an ambition of promoting pharmaceutical production on the African continent, including vaccines. But we have seen a very, very slow progress on that. In 2016, countries in Africa met in Addis Ababa and came up with what we call the Addis Ababa Declaration on Immunization. And one of the 10 commitments through that ADI commitment was vaccine production on the African continent. So I think there are here and there very timid initiative, but which needs now to be accelerated, which need to be supported. Now, having said that, with regards, and I've seen a lot of questions in the chat box on the equitable access to the vaccine. I think one of the real objectives of setting up the COVAX facility was really to make sure that countries in Africa, in particular low, middle, and low income country, or even low middle income country, can get access at the same time, the vaccine than the rich one. I mentioned at my introductory words about really the very sad experience we went through during H1N1, because fortunately, that was not a very severe pandemic. But if it was at the same magnitude that what we are going through, then it could have been a catastrophe in Africa. So the very same essence of COVAX, it's really to make sure that at least 2 billion of vaccine doses can be secured to be distributed to the 92 low and middle income country economies, including most of the African countries, 46 in general, because 8 of them are currently under the group of who can afford to pay the vaccine themselves. And what has been in place was that for those countries that will be eligible, a minimum of 20% of their general population could access the vaccine. So this is really the equity that is at the center of the COVAX initiative. And there was one interesting point in the chat was saying that is countries in Africa having even a voice at the table when these things are discussed? Yes, yes. WHO, African Union, we are pushing to make sure that a country, low middle income country, are equal partner, even though they're not putting enough money, but we know very well that they can contribute to additional ideas and things like that. And it's working quite well. Countries are being represented. African voice have been heard. And I think this is what we should all promote it, to make sure that equitable access, it's become a reality.
Yeah.
Thanks, Adrian.
Sawa. Margaret, let me come to you, because we've talked at a high level about the things that are needed for communities to be ready. Can you break this down for us at a practical level, right? At the community level, who are the people who need to have conversations if this is going to take the kind of, if we'll get the kind of uptake that we'd like to see from the communities themselves, reducing that vaccine hesitancy gap and that trust gap at a practical level? Who are the people in your own community you're thinking, I would talk to so-and-so and get them to say this. I would talk to so-and-so and get them to say this. I'd talk to so-and-so to get them to do this. Really practical, on the ground perspectives.
Okay, thank you so much. As what I've said before, you should involve all the stakeholders in that community, starting with the local administration, the CHUs, the CHCs, the CHWs themselves, and the community itself. So in order to succeed, I think the best people are the community health workers, because they really understand that community. And even the religious leaders, the mosques, the churches, or the organizations which are there in that community. And what you should focus more is about the myths, because if you don't address the myths surrounding the vaccine, I don't think those are some of the concerns from the community members. And as what I've said, before you start everything, let the community itself own the whole process from the word go. Let them get updates. Let the community health workers get the right information concerning the vaccine. Because if they don't get the right information, they'll mess also the community. So the key people are the community health workers, because they really understand the community very well. Thank you.
Super useful, super useful. Dr. Githinji, I see we only have 4 minutes to go. And I know there was, I don't know if you have any outstanding questions or one big question you'd like the panel to answer. And then there's a call to action before we close.
Yeah, I think very well handled. There was the big issue. There was a question I saw there about, and maybe we may have the answer now or not, and maybe this is to Richard or Emmanuel if you have the answer, about the administration, the number of doses, the route of administration. If we know at least the 44 or so COVID vaccines that are in clinical stage, are they oral? Are they injectable? Are they, just a quick comment on that, because that question I've seen it arise, because that also determines who the vaccinators are. Because if it's not oral, then community health workers then become extremely important in terms of conversations. But then you need, higher skilled health workers to do the vaccination. Could you comment on this question? If it's known or not known right now, there's a question on that. Richard or Emmanuel?
Yeah, maybe I can go very quickly on that. Yeah, on the 9 to 10 candidate vaccine that have entered the last phase of clinical trial, most of them are injectable vaccines, so there is no oral vaccine. The majority of them are going to be using 2 doses versus 1 that we used to. I think there is only 2 candidate vaccines that are currently going to be using 1 dose regimen. With regards to cold chain, in terms of storage of these vaccines, maybe this is a more technical question. There are different platforms that have been used to develop these vaccines. They are not all using the same platform. And some of these vaccines may require what we call ultra cold chain capacity, which means that being stored at a cold chain up to minus 60 or 70 degree centigrade. But the majority of them will definitely be using the normal cold chain capacity that we're using in EPI, +2 to +8. So it's very difficult in conclusion to say which one of these vaccines is going to make it in the finishing line. But in the scenario that we are doing in terms of logistics and capacity, we are trying to factor in all of these different scenarios so that it can inform country planning process when it comes to cold chain planning and expansion. Thank you.
Yeah, and thanks, Richard. And to add on that, this is Emmanuel. To add on that, as this information evolves and changes, information from the vaccine trials, for example, in Uganda, we have what we call the NITAG, the National Immunization Technical Advisory Group. So this is a team that is looking at all these different available vaccines and putting down the information and putting down the requirements in terms of resources, in terms of the cold chain, in terms of the other technical issues related to the vaccine. And this team is supposed to advise the Ministry of Health in terms of the vaccine that would actually be used by the country. So the NITAG is also involved in these preparatory stages that I'm talking about. So, and they're getting this information about vaccine trials, and they are definitely in position to advise the government on which one to take on.
Thank you. Thank you very much. I know we are going over time. We'll request a few minutes of your time to read the call to action. There's one issue that remains hanging on all of us, and I think it was raised by Chizoba. It's something we've talked about before. How do we make sure, and I saw a question on based, and somebody was referring to Uganda. I don't know why they picked on Uganda and level of corruption. Corruption is almost like a continental issue. And not only continental, it's a global issue, but they picked on Uganda this time. And the question is, how do we ensure, how do we make sure that the people of power do not take the vaccines for themselves, irrespective of the policy frameworks on who should access? I think that remains a question we haven't answered today. We should actually think a little more about it and say, what is this civil society can do to ensure vaccines go to those who need them, not those who have the power to get them? So I'll come over to you, Chizoba, to read the call to action, and then I'll ask Edwin to wrap up. And thanks for allowing us 5 minutes over time. Over to you, Chizoba.
You're on mute, Chizoba. We can't hear you. The famous words of 2020.
That's right. Okay, so here is a call to action that has been prepared by this group putting together this, this webinar. And we really want people to take this home and think about them and locate themselves in one or more of these actions and say, what can I do to take this forward? So these calls are specific to different actors and players in the system. So the first thing we're saying is that we're calling on African countries to leverage the COVAX facility. It's a good thing. Leverage it to strengthen the pooled and bargaining power to ensure that people of Africa can access a sufficient share of vaccines from the global supply. We are calling on African governments and their regulatory agencies to remove barriers to regulations and approval to COVID-19 vaccines across Africa. This does not mean letting every and everything come into the country, no, but it means that we should work together at the continental level to harmonize our regulatory processes and fast-track country authorization of safe and effective COVID-19 vaccines once they are developed. So the regulatory authorities have to be engaged from the get-go, and they have to put in place the systems right now so that they can act as soon as the vaccines become available. They can act, regulate, and approve the vaccines for use in our countries. We are calling on governments and private sector, as well as the global community, the global donor community, the global financial community, to promote regional manufacturing capacity of vaccines to support the continent's demand for COVID-19 vaccines by enhancing intra-country trade, removing IP barriers, enhancing the science and technology that drives vaccine development. I will make bold to say that there are many Africans who are leading teams across the world in these countries that manufacture vaccines, who are leading teams that are actually bringing these vaccines to life. So let that come to our continent. We are also asking that the country immunization programs establish country committees to guide the country preparedness for the acquisition and equitable distribution of the COVID-19 vaccines in a timely manner while prioritizing vulnerable populations and staying true to the allocation framework that has been developed in country based on the country needs. We are asking the government to allocate sufficient funding to secure COVID-19 vaccines and to strengthen the capacity of immunization systems to deliver these vaccines, including expanding supply chains, ensuring the cold chain requirements are met, ensuring that demand generation activities are not just put to the side, but they are supported and funded to the extent that they are effective. Like they say, these vaccines will not deliver themselves. And when they are delivered, if people don't accept them, then it's all a futile exercise. So we must allocate sufficient funding to support the end-to-end delivery of these vaccines. We are requesting strongly that we take seriously the issue of community engagement, engage the community to address mistrust, minimize vaccine hesitancy, better inform key opinion leaders and the general public on the need and the value of the vaccines and the benefits that we will derive both from our public health and also for our economic recovery on the increased uptake of the vaccines. We are saying that partner with civil society organizations and other local partners to augment government efforts. Government cannot do it alone. Use the assets of the entire society. It's a whole of society effort. And then galvanize innovations to ensure that people are well informed about COVID-19 vaccines and that we put in place measures to enhance trust. Trust is critical, but trust in the government response to COVID broadly and trust in the COVID vaccine specifically. And we need to tackle misinformation about the COVID-19 vaccines. Finally, the COVID pandemic is an opportunity. As much as it's a challenge to the system, it is an opportunity for us to restore routine immunization, for us to recover from the pandemic, and for us to build our systems back better to what they need to be. Thank you very much.
Thank you very much. And Edwin, would you like to make any closing remarks? I must thank everyone for joining us. It's been a fantastic session. I must thank our panelists, Margaret, Emmanuel, Richard, and Chizoba for fantastic engagement. And all of you, our audiences, as always, joining us and asking so many questions. You know, the questions today, we'll try and summarize them and see what we can do, but we must appreciate everyone's engagement in this. Thank you very much. And over to Edwin for your closing remarks.
Yeah, no, absolutely agreed with you. I think that I come out of this knowing this is just the beginning of what is going to be a long journey. And thank you to the panel for getting us to, the collective to understand better what is going on and what is planned. And I suspect we'll come back to this question again and again until we wrestle COVID down to the ground, because the first level challenges we've identified today, they will yield second and third and fourth level challenges that we'll need to constantly tackle collectively together. So thank you to the panel for that. To everybody else, the next webinar is December 4th. It is the last one of the year. And so, topic, I think it's going to be Dr. Gethinji and I really reflecting where we've come from the first webinar, which I believe was mid-March, I think it was, to now, and what are the kinds of challenges that await the African continent in 2021. So please, as always, sign up for those. Looking forward to a robust conversation then. But everybody else, thank you for joining us today. Sorry we've gone a bit late. We will share the call to action broadly as well as sharing the recording. Please share it with your friends and colleagues, because it's important that we keep sharing this information with everybody who requires it to make a decision. Asanteni sana kila mtu. Take care. Have a good one. Kwaheri.
Thank you, and thank you to the back office team that always makes this happen. Thank you very much. Bye-bye.
Thank you. Bye.